It's a privilege to be here because PEPFAR, I think, represented really something very significant from the American people. And I think it represented what we could do as an American together with our Congress and our president. And I think when President Bush announced PEPFAR, I was already working in sub-Saharan Africa. And it was a very difficult time. It was the 90s, late 90s. I was out in Kericho district, out in Kenya, and at the Kericho district hospital. And we had a fabulous matron of the hospital, but she was sending people home to die and telling them that there was nothing to be done. Now, this was at a time when I had patients here in the United States that were on effective treatments, that were living and thriving with HIV. So it was a very dark time. But when President Bush announced PEPFAR, I got on a plane, and at that time I was in DOD, and DOD was not supposed to be part of PEPFAR, but I brought like a 400-slide PowerPoint and went to Joe O'Neill's, who was responsible for really setting up PEPFAR, and just stood there and waited until he let me in, and then I wouldn't leave until he understood why it was important that all the agencies within the U.S. government were involved. And so I did PEPFAR on the side for 2 years, and then it became a real calling. Went to CDC for 9 years, and now at the State Department. I want to have a little bit of reflection about where we have been with communities of faith and where we have been with faith-based organization. And I'm separating those two concepts because at the beginning of the epidemic and the beginning of the death and devastation of HIV, particularly in sub-Saharan Africa, it was the churches that stood up even before the FBOs really could stand up, because they didn't have really resources to combat the disease. And so it was the churches in the communities that held the hands of the dying and the sick. It was the churches that stood over the funerals and comforted the children. It was the churches that understood what families had child head of households and grandparents leading households. It was the churches who stood up. And I think along the way of our work of PEPFAR, we lost some of our engagement directly into the churches. We have never lost our connection with our faith-based organizations work. But I want to talk a little bit about both the role of the churches and communities of faith as well as the faith-based organizations. Now, in 2015, there was a big article about all of you and the work that you do. And this is a mainstream journal, The Lancet, who talked about the importance of the work and really went through country by country and documented the depth and breadth of the activities of the faith-based organizations, where they are recognized by governments and where they are utilized by governments but not recognized by governments, and really went through how important their extensive experience within the communities have allowed the faith-based organizations to have a unique position. In addition, when I was working in Africa, it was the faith-based organizations that were at the end of the road, sometimes in the most difficult and distant areas. In some of the places in South Sudan, where my daughter was working for CMMB, it was the faith-based organization that took in the American workers at night, no matter what organization they were working with. The Baptists would take them in so that they could be safe at night, so that they could go back out and do their work. And so it's really been critical in all different aspects of the, so this is like my slide to show kind of my concept of what happened. When PEPFAR was announced, I think we had a strong relationship with the churches in sub-Saharan Africa and throughout the world and throughout the Caribbean and Asia where we were working, because they had the connections into the community. And so when we wanted people to come forward where people had lost hope and there was quite an amazing level of despair, it was the churches that said, no, I think these drugs could be life-saving. It was the churches that dealt with stigma and discrimination, and it was the churches that brought the people into the clinics to get the life-saving treatment. And then now, I think some of that relationship is not as close as it was. And so we have spent the last year and a half, the last 18 months, mapping this out and sending emissaries out into country after country to really map what is available at all the different levels of leadership of faith in the different countries so that we can tap back in successfully, and then working with organizations like World Relief to really see what can be done with pastor and leadership training in each of the churches around core issues that now are affecting many in sub-Saharan Africa and other places we work in. I mentioned sub-Saharan Africa because 75% of the burden of HIV is there, and about $4 billion of US government dollars through our programs are there every year. So it's our largest investment and therefore allows us to have a greater impact. Just a quick thing on PEPFAR. When PEPFAR started and President Bush announced that he wanted to put 2 million people on treatment in less than 5 years, Anne and I and Bill Steiger had a heart attack because we knew that we were the ones responsible to translate what was close to 0 in sub-Saharan Africa to 2 million. In a way that we knew that we had to bring everyone together, but weren't really sure how to do it. And governments have a lot of bureaucracy. So we actually had to grant things. So, that takes sometimes 12 to 18 months. So now you only have 3.5 years left. So, but it was amazing to me that we got to the 2 million people on treatment. And today we have 14 million men, women, and children supported by US taxpayer dollars in sub-Saharan Africa, the Caribbean, Central Asia, and Eastern Europe, and Southeast Asia. And this has really been due to that partnerships that have been developed, including our faith-based organizations. Importantly, 2.2 million babies have been born HIV-free, and I mention that because that's going to become critical in another piece of what I talk about. Because it's not only, and you all know this, the immunization, the maternal child health work has resulted in a 75% reduction in under 5 mortality. Yes, but no one planned for them to be 15. So we have a problem that no one planned for. And I ask the World Bank all the time, when you started the push to improve under 5 survival, who did the calculations of how many schools would be needed and how many jobs would be needed and how much opportunity would be needed so that the young people could thrive and have communities that were thriving with them? And they looked at me and were like, we didn't do that. So we have communities where the majority of the children now are not in school because there aren't space for them in many of the schools. About 2 years ago, we launched what we call Dreams, and you'll hear more about that tomorrow from Susan Hillis. We have a whole team coming up here to be able to be with you, and I'm privileged to be here tonight. But Dreams is really focused on those adolescents and really trying to bring comprehensive, non-medical interventions to young women and girls to really have their opportunity to thrive in these communities. And over the last 2 years, with a really grassroots, indigenous, often with faith-based, and using our orphans and vulnerable children's programs, we've seen about a 25 to 40% decline in new infections in young women without a medical approach. So, PEPFAR, the President's Emergency Plan for AIDS Relief. If any of you are our partners, you know that we have a big emphasis on partner management and accountability. So if you were measuring things before in early PEPFAR, you're measuring them about 10 times more than you were at the beginning of PEPFAR. This has been important so that we can see the clients we're serving. So we collect data down to the site level, and if you go to pepfar.gov, you can see every site and the information from every site on that website and the results and the targets from that website. Because we think it's really important as communities get more and more facile with technology to be able to see what is happening in their community on a regular basis. So that's available. Now, this is the total burden of HIV in the world. So it's displayed by the bigger the country, the bigger the burden of disease, and the darker the country, the number of adults and what we call the prevalence, what % of adults in those countries are infected. And they range everywhere from 48% of the adults in Swaziland to about 5% in some of the other countries. But you can see every country is represented with some degree of HIV/AIDS, with a major part of the concentration in sub-Saharan Africa. What we have learned through PEPFAR is dramatic impact is possible. And that's been the exciting part, that we can really see the translation of funding into action and into impact and really changing the face of the HIV/AIDS pandemic. In the areas where we have been most successful, it has been a country where there has been political will to talk about HIV/AIDS, where there has been political will to do some investing in HIV/AIDS, and where there has been a relationship between faith-based organization and governments to really implement and execute the best programs possible on the ground and ensure that we have the policies to make the program successful. Now, how many people do we have here from West and West Central Africa? Okay, you have a problem. We have a problem. We have put a significant amount of money into West and West Central Africa, but we will not succeed if we do not change the policy of collection of formal and informal fees that become barriers to the poor in accessing health care. So we really have to take this on collectively. That's not to say that we want people to not have the human capacity that they need and the infrastructure to execute health care. But we know from East and Southern Africa that by decreasing the fees for pregnant women, brought the pregnant women from the communities into the clinics and allowed them to receive comprehensive care. So these are the things that we're talking about, the kinds of policy pieces that we have to work on. Now, you don't need to know anything from this graphic, but to know that when PEPFAR started, less than 50,000 people knew their status and were on treatment. In each of these countries now, between 52% and 85% of all adults, that first line, the red line, know their HIV status. That means that all of the adults nearly have been tested in Swaziland when you get to 85%. So this is what is possible when everybody is working together. Now, that red bar is how many people know their status. The orange bar is, do they get on treatment then? The shocking thing is almost 90% of everybody who knows their status has gotten onto treatment. So the message that treatment can be life-saving, the message that it's important for you to stay on treatment, these surveys are done at the community level, so they're not biased to whether people went into the clinics or not. This is at the community level to really see what we have done. Importantly, that blue bar is the people who are what we call virally suppressed. That means every day these clients are taking their drugs, even if they have to walk back to that clinic 3 times in that month because they only got a 1-week supply each time they went. They've continued to do that so that they remain virally suppressed. Now, why is this important? This is important for their health. It's also important that they can no longer transmit the virus to others if they're virally suppressed. So although we don't have a cure for HIV, we can make it so people can live successfully with the virus, and importantly, also not transmit the virus to others. So this is terrific. This is what has happened in just 5 years in Swaziland. That dark blue line is what we call prevalence. Again, that's the % of the in each age group are already infected with HIV. And you can see that we've been able in 5 years to decrease the prevalence by almost 5 to 10 prevalence points. That's almost 50%. I call your attention to where those lines peak. They peak at 50%. So 50% of the adults in Swaziland are infected. But the good news is we're dramatically decreasing the number of young people who are getting infected today. And that's very important for all of us. This is an example from Namibia. In 2 years, they got to 68% community viral suppression of all adults. 68%. Can you imagine 70% of anybody that 70% of the people in here probably haven't been to their doctor in the last 6 to 12 months? These are 70% of the individuals who are coming to the clinics regularly, and it represents such a large component of the community. Now, that was all the good news. Now here's the difficult news and why you all are absolutely key to the solution of the future. We are not diagnosing healthy adults and children. So remember, when you get infected with HIV, you are asymptomatic. That means you don't have any symptoms of the disease for 8 years. So for all that 8 years, inside your body, your immune system is being destroyed quietly every day. And you're transmitting the virus to others. And yet you don't know. Because in sub-Saharan Africa and in many places, including the United States, well people, or people who perceive themselves to be well, do not like to go to the doctors or the clinic or the nurses, and they just don't want to be in that healthcare situation because they are well. And so figuring out today, how do we create an environment in the communities, in the churches, and in the health centers where well people would come in and get prevention messages, be tested. If you wanted to treat early hypertension, you could do that. That is pennies. Early diabetes. You will not prevent NCDs if we don't figure out together how to create an environment at the clinic where healthy people see coming to the clinic is valuable for their health. And that is a hard, hard thing to do. It's particularly good and difficult, and I'm looking at all the fabulous men in the audience. They are the worst. When I talk to them at the clinics, they say to me, well, A, we don't want to see a woman, nurse or doctor, because they gossip about us. Now, I want to reassure you all that we really do not gossip about you. We have other very interesting things to gossip about, but it's not you. But I remember that many of us as women have had to go to male OBGYN people our entire lives and have our babies delivered there. But okay, we want to meet you where you are, and we understand that you don't want to see women. So the great news is, in many of our communities, there are male nurses and physicians that can help us out in this issue. They also don't want to come into a place where they don't see other men. They're very uncomfortable when they come in and see a lot of mommies and babies. So in a whole series of communities, we've created these things called men's corners, not changing any infrastructure, not doing anything else, but when the man comes into the clinic, he sees a place where there are other men. And the word of mouth goes out there that this is a welcoming place for men. And I think we're really working on that and trying to create that space. But if you're not pregnant, you also do not see yourself in the healthcare delivery system. And so these are issues. If you are 14, you don't see yourself in the healthcare delivery system. So I love it when people are talking about universal healthcare coverage and universal access. We have a long way to go because the communities don't see themselves as having a role in getting healthy care out of the health centers. So this is way too much information for you, but I'm a big, okay, really, I'm a data geek. And I had this big thing for data. So in these surveys, we've gone through every single age band, and we have here males and females. And you can see that we're missing more than 50% of the young men between 15 and 35, and about a third of the young women, particularly between 25 and 30. So this is our challenge together, and we believe that you can solve it. Now, I'm just going to cover a couple of things related to dreams. This is when I talked about that prevalence of disease and how women are infected and men are infected. Women are infected. See those turquoise, lighter green bars? That's the women's prevalence. The smaller bars at the beginning are the men's prevalence. Now, when you look at this, you have to understand that people are getting infected from others. And so if there's no young men of that age group that are positive, you know immediately that the young women are getting infected from men that are 5 to 10 years older than them. And this is another critical role for the churches. This is that youth bulge that I talked about. This is Zambia. We have twice as many 15 to 24-year-olds as we did at the beginning of the epidemic. 60% of sub-Saharan Africa will be under 20 by 2020, and the median age in Uganda is 14. So this is why, to us who work on and are trying to decrease the rate of HIV, this becomes a real crisis for us. Now, I'm not going to go through the DREAMS data because you have a great expert that's going to do that tomorrow with you, but we've reached 2.5 million women, girls, and we've had a huge impact. And this just shows the data of the percentage of decline in new infections. And this is, of course, as I said, we go by every site, so this is every single district that we've worked, and this is districts with a more than 25% decline. And these are districts with less. And I show you this because we are not having the same impact in highly urbanized areas. Nairobi, Lusaka, Johannesburg, Durban. And we think there's a migration, particularly of 15 to 24-year-olds into informal settlements in these large cities, not having the social fabric to which they left and not linked to any churches. And there aren't churches and outreach into those informal settlements. So when we started, I made a point of talking about how many of the FBO structures were at the end of the road where the need was the greatest and there was no one addressing it. That need has shifted and is now in these informal settlements where people don't have the same social wide arms of love and compassion around them. And the risk and the outcomes for these young girls and young men are quite dramatic. So I'm not going to go through all of that data. If I could just mention for a minute that the orphans and vulnerable children are getting older too. So I know a lot of people like to work with children under 5, but the problems are really in the children 14 to 17. And we need to have programs for them. And so I know many of you are involved in children's programs. Make sure your churches, make sure your FBOs have outreach for those children in that older age group. So I'm not going to go through any of that. You're going to hear this tomorrow, so I want you to be able to think about this overnight. This is the sexual violence of young girls where first sex is rape by country. It's between 20 and 35%. Now that's why I talked about how we need to bring the churches and FBOs together, because Sunday morning, both the perpetrators and the victims are in that congregation. 65% of those who have been raped reported it to someone, and no one did anything. This is the role that we have to have for the communities and the churches to put that wide arm of that reckless and unending love of God around these children. And we have to stop concentrating completely on post-rape care, which is what we had been doing. And we have to get to a place where we can speak about it and prevent it. And I think that's why I'm excited about being here. That's what I wanted you to really hear. We have to deal with these very difficult issues. These issues put our young girls on a trajectory of early pregnancy, child marriages, and dropping out of school. Now, because I know I only have 5 minutes, I wanted to also just mention that we are now investing in cervical cancer in many of your countries to be comprehensive, but the cervical cancer work that we're doing right now is very much focused on HIV positive women because their risk is 20 to 40 times more HIV negative women. So we want to start there and prevent cervical cancer and mortality in the women who have HIV and work with the countries to deal with the HIV negative women. So I wanted to leave you with these key gaps as we see them. diagnosis of well children and young adults, to really find out if they're HIV positive and getting them on life-saving treatment, finding men. So what's happening with men is they're presenting late with end-stage disease, where we can't restore them to full health. They're presenting with tuberculosis in their 40s. They're presenting with opportunistic infection in their early 40s. That is happening because they've been infected for more than 10 years, and they have felt well. So we have to break down that barrier. So this talk is really how do we together with the churches and with you all break down the barrier, and I'm going to move right to the conclusion. So we need the communities of faith engaging to ensure that Sundays, the church is conveying the need that you can be healthy and have HIV and need to be diagnosed, and if you are, you can thrive. So that's an exciting concept. And we have to ensure that the FBOs are moving with the demographics of sub-Saharan Africa, which is a huge demographic shift from rural to urban areas and a large demographic shift in young people under 24. And collectively, we have to really deal with the consequences of those issues. I know Susan is going to talk about, Susan Hillis will talk about this tomorrow. But this is a remarkable number that the majority of communities are in churches on Sunday. And so the fact that we haven't been working through the pastors and the communities of faith to really convey our critical messages has been our problem. So you can see that anywhere from 62% to 88% at least are attending church 1 to 2 times a month. And this is everyone, male, female, young adults, children. And so this is our opportunity to really start breaking down some of the barriers and concerns that we have and to really address some of these practices that are occurring in the communities that are particularly putting people at risk. Now, in the back, I have this manual. This is the Sexual and Reproductive Health Policy Manual from the Evangelical Association of Malawi. We know that these exist in country after country. These are the platforms we're taking to the pastor because it's very clear that the church already has positions that are critical for young people and preventing sexual violence. The church stands strongly against and condemns all forms of gender-based violence. And to build the capacity of the churches to implement the programs, the churches to implement the programs to prevent sexual gender-based violence. This is in the manual of the Evangelical Association of Malawi. Susan has them from Zambia. And it talks about male engagement and the importance of men and the importance of men in the family and how important it is to have these messages and the capacity building for men and leadership within the church. So thank you. I think I'm excited about your next 3 days. We have different groups coming up and talking, but what we know, when it seemed daunting to get 2 million people on treatment and now we're at 14, I know it may seem daunting to talk about sexual violence and rape of children under 15. But we always have to move where the need is, and we have to remember that, and for all the things that I've done wrong, I am always thrilled that there was a New Testament of redemption, a New Testament that recognized that we have failings, and a New Testament that allowed us to have salvation. And the church needs to bring salvation to those communities to prevent this gender-based violence and these other really negative practices that are impacting the health and welfare of young girls and also impacting the health and welfare of young boys. So thank you for this opportunity. I appreciate the time with you today.
Thank you so much, Ambassador Birx. I know you guys want to ask her a few questions, but she only has a few minutes, so really short, to the point, and we'll try and get a couple of them in.
Fantastic.
Okay? Yes?
How can we get PEPFAR?
Use the microphone, please.
How can we get PEPFAR support for cervical cancer screening through a program that we already have in Cameroon?
Oh, it was good until you said Cameroon. Okay, so we have prioritized, okay, we have two problems. One, we're having a huge problem with fee policy in Cameroon, keeping pregnant women away from clinics, particularly the poorest among. It's not so much the formal fees, it's the informal fees that are collected by healthcare providers that are facilitated by the government using formal fees. So we're starting the cervical cancer in countries where the female prevalence is over 10%. You're at 5%. So we're learning from the high burden countries, and we will probably get to you in the next 18 to 24 months. But if you have a pre-existing program to which you want additional support, if you just give your card to Susan Hillis, we will absolutely look into that specifically to be able to support you in that. But in general, as a scaled countrywide initiative, we're starting with the highest burden countries.
Two more? One and then... Yes.
Thank you so much, Ambassador Birx. I am Pius T, the principal recipient of PEPFAR funding in Cameroon. I'm the PR, and I'm glad to see you. Really glad. The first thing has to do with testing those who are healthy and moving around. With the new policy of target testing, how can we actually overcome this? Because actually, we are not supposed to do any mass screening anymore. Yeah. We're not supposed to test those who actually are suspected to have the virus before we test. We don't do mass screening anymore, and that is with directives from your office. Anyway, the second thing is...
It's true.
Yeah, the second point has to do with fees in Cameroon. You will really be happy with what we have done up to date. We have done a lot of documentation. We appointed focal point just for fee review in the whole country, and they have been working with the ministry. They have good documentation, and they have actually shown where there are excesses and so on, and that is being addressed as I'm here. So you will be having a report on that. We presented the first draft to CDC Cameroon, and I think Rachel and Emily were really very happy with that, and you know that something has been done. Thank you so much.
Great, so let me talk a moment about mass screening. So what we have found in mass screening and in standalone voluntary counseling and testing is the worried well have been tested a lot. So when I showed you the country where 50% of the adults were positive, they were testing that way and couldn't find more than 1% positive in a country where half the adults are positive. So what we are trying to do is find the mother, the father, the partner that's positive, and then get out to the community to test their partners and their children. And let me just say a moment, both biologic and non-biologic children that are in the household. And why is that important? Often the non-biologic children represent children who have been taken in from parents or relatives who have died and have a higher prevalence of HIV. So it's just, we're starting with the targeted testing to really, yet last year we did 85 million HIV tests. We can't continue at that rate. There's not enough financing. So we're going to try this and see what happens. But we constantly, if you've been a PEPFAR partner, you know that we continue to evolve and change. I know that's scary to everybody. But so if this doesn't work, don't worry. We will be evolving and changing and working to really find what does work, because we're all in uncharted territory to really figure out how to bring healthy people into the clinic and find them.
Yeah, could you speak about the role of religious leaders and faith communities in global advocacy, especially in times when a lot of us are worried that the AIDS response is kind of weakening?
I think that if you remember the early days of PEPFAR, it was the faith communities that really lobbied for the PEPFAR funding. They went to our Hill and talked to their congressman. Because in the United States, if you're in Iowa or Kansas, it's hard to understand sometimes why, as American, we care for the global world and are investing $6 billion in HIV a year. But the faith community, particularly in the United States, understood that, and we're a powerful group of advocacies. We are taking advantage of our administration today to really launch new, and I didn't go through that, but launch a whole, we have a new faith-based initiation strategy and involvement strategy and a community of faith strategy to really move resources to indigenous organizations to have this kind of reinvigoration of the communities at the level utilizing religious leaders and faith-based organizations. But in the United States, at the beginning of PEPFAR, those were the organizations that made this happen. They were the ones that made it happen. And they've been a little bit quiet lately.
Right.
So
I want to follow on to that question because CCIH has Advocacy Day on Monday, right? Some of you are staying in order to go up on the Hill and talk to Congress. What do you want them to say? You've got people from the countries who are going to be on the Hill on Monday. What do you want them to tell people?
I think two things: letting them know that you're proud of the investment the American people have made, and that you believe it's a representation of the best of what American does, and that you appreciate it's been bipartisan. We still are one of the few programs that are equally supported by Democrats and Republicans. It's a thrill to me every day to be in that position. We don't ever want to take advantage of that. And I think third, remind them that the infectious diseases of HIV, TB, and malaria could be tackled. We have the tools. We just have to make sure that we finish the job. And I think really alerting them to that. But if you come from different communities in the United States, I think really letting them know that you're behind this. And if you can see your particular, now, for those of you from Africa, I tell you, they love it when you say we really appreciate the American people for PEPFAR. That warms their hearts to have that said, because I know you are grateful, but they like to hear it too.
Thank you very much. I'm Karen Sichinga from the Churches Health Association of Zambia, CHAZ, and we've worked with PEPFAR since the beginning. Thank you very much for the funding, but it seems to me from the experiences that the PEPFAR funding was more predictable then, and over the years we find that it's more predictable. For example, you can sign a grant agreement for 5 years, but each of those 5 years, the funding seems to dwindle each time. So it has become less unpredictable, and my question is to you, and you're the right person, and we're very lucky that you're in this room this afternoon. How can we make the PEPFAR funding more predictable? Because it did make a difference.
So, I'll tell you what we use for analysis. So we don't actually see the decisions made at the agency level. So if you are a PEPFAR implementer, you get your money either from the Department of Defense, the Centers for Disease Control, or USAID. What we have asked them to do is to very much fund based on performance and achievement and need. So if you have done a great job and your prevalence is dropping, and you have 90% coverage because you've been so successful, you could lose funding to have, not totally, but I mean, you wouldn't get increases like the others who are working in areas where the disease was still spreading.
So you become enemies of your own success.
Yes. Yes and no. So this is an issue we are truly dealing with, because we are trying to, in those districts that have had that high achievement, we are trying to define what the long-term role of PEPFAR and that investment should be. And I can't give you an answer yet, because we're really looking very seriously at that. And that will be predictable. and dependable. It may not be as much as you think you should have, but that will be much more predictable because we will be maintaining a steady state to continue to shrink the epidemic. And so that is being worked out now. There are areas of Zambia that is true in. It is not true in the Copper Belt in the north, where less than 50% of people are on services. I think we had a gentleman.
Thank you very much for your presentation. I'm Henry Perry from Johns Hopkins University. There's been a groundswell, I think, at the current time of interest and awareness of the value of community-based approaches to addressing health problems, and particularly child health, maternal and child health, and increasingly for tuberculosis and malaria. HIV and PEPFAR and other HIV programs have been slow to move beyond the facility into the community, and particularly to embrace the role of community health workers in ending the epidemic. And the head of UNAIDS has said that community health workers are the secret for ending the HIV epidemic. So I'm wondering what your thoughts are about how PEPFAR can be a part of this movement and where we are now at the present time in moving into a stronger role for community-based programming.
No, thank you for that. So we have spent the last 2 years trying to get the data on how many community health workers we're supporting, and secondly, are we paying them? And so 2 things are happening that should make you a tiny bit happy. We are telling the agencies that they need to be at 40% indigenous funded in 18 months and 70% in the next 30. Because we believe, as you described, if we're going to have a sustained program, it has to be completely indigenous. We know we have to get to 100%. And I don't mean as subs, I mean as primes. And also documenting the number of community health workers and paid community health workers. And this has to do in getting to the policy at the government level to ensure that community health workers are paid. Right now, many of our partners are using volunteered or stipend community health workers. That is not sustainable, and we agree with you. The community and the meeting of the needs of the community through a community health worker is going to be the long-term solution to maintaining control of these epidemics, but also pointing out when something is different. When you talk about the global health security agenda, you don't have a global health security agenda without knowing what the diseases are in that community so that you can find the ones that don't match. And the community has to feel like they're engaged with and part of the healthcare delivery system through the community health workers. So we couldn't agree with you more, and we have dramatically increased our investment within community health workers. I'll tell you what happened. At one time, we were going to leave South Africa. There was a whole plan to decrease our funding in South Africa, but they have 7.5 million people infected, and at their current rate of new infections, they could hit 10 million or a third of their country infected. So we have continued to invest with South Africa, but in that time when it was thought that we were leaving, we had 10,000 community health workers that we were paying for. The first thing the government did was fire all the community health workers. So now we know, I mean, it was a great example for us because now we're having to rehire them and redeploy them in South Africa. But it's a good example for us that we have to create sustainable programs that the government also recognizes so that 20 years from now, 30 years from now, those solutions are fully funded and respected within the community of work of healthcare. Giving you your exercise.
Yeah, yes.
Tito Zoela from CHAM in Malawi. In terms of the investment that PEPFAR usually has in Malawi, it's mainly targeted at the lower to mid-level healthcare workers. So there's a lot of questions that the medical doctors and the graduate nurses have in saying that how come we're not being used as part of the program for HIV. You find that there's a lot of nurses and clinical officers who are involved in the PEPFAR programs and HIV care in Malawi. But what is your view in terms of involving the higher level cadres? Because I think they're critical in terms of the longer sustainable HIV management and care. Thank you.
Well, that's a great question, because you are right. We have really worked, Malawi had one of the lowest doctor-nurses ratios of any country in sub-Saharan Africa, but you can see by their success that it didn't hold them back, which I'm always so impressed that Malawi worked with what they had, didn't look for what they didn't have, and was the first country in sub-Saharan Africa to launch B+, which was treatment for all pregnant women lifelong with 8 ARVs. Stood alone when the rest of Africa had moved, so congratulations. We are working with medical schools and nursing schools to improve the curriculum in a whole series of countries in sub-Saharan Africa, but that's the first time I've heard that question. So I don't have an answer for you, but I will take it back and ask what we're doing and work on getting an answer for you, because it's not something that was any intention, but sometimes when you're focused so laserly on a piece of work, you forget the other side of the equation.
One on this side and one here in the middle. Yeah.
Thank you very much. My name is Judith. I'm from Zimbabwe. I'd like to really appreciate your presentation and the passion and the knowledge that you have on the subject. My comment is on the gaps that you identified, and my concern and passion is on the issues of young girls who are having their first sexual debut through violence or through, I don't know how best to put it across, but forced. And I would like to say that maybe the FBOs and the church would be the right forum, especially to discuss these issues. We have had a situation whereby this subject is being discussed maybe with children on their own, with parents on their own, and yet there are cultural issues and other issues whereby it would be best to bring parents and children together and have these discussions so that they can be able to support each other. And the safest place to carry out those discussions would be through churches and through other faith-based organizations that are recognized by the communities as safe places to discuss such subjects. So I'd say going forward and dealing with those gaps, maybe the faith-based organizations and the churches might be the right places for us to tackle, especially those sensitive issues.
Couldn't agree with you more. And it's why for the 9 to 14-year-olds, we moved $50 million in through our orphans and vulnerable children faith-based groups to really work on this issue. I will tell you that was over a year ago. And the fact that you don't know about it, and Zimbabwe was one of those countries, and the fact that we haven't gotten the traction just tells me that this is still a difficult thing to discuss. And I think we have to give people the freedom and the time to understand the issue, get comfortable with it, and begin discussing it within the churches and the faith-based communities. But I think, you know, you are all emissaries that can go back and start those dialogues. And thank you for recognizing that. I couldn't agree more. It's why we are putting all this emphasis and why we are returning to what we really talk about is delay of sexual debut and total risk avoidance. But it's very difficult to talk to a girl about delaying sexual debut and her family when a third of the girls in the community's mothers and aunts have been raped as their first sexual experience. So these are the issues that we have to really take on in a very direct way. So thank you for raising it. Couldn't agree more.
I think.
Thank you very much, Ambassador Birx. Dr. Tony from Uganda Protestant Medical Bureau. Together with our colleagues, the Uganda Catholic Medical Bureau, we've been recipients for PEPFAR funding in Uganda. And of course, as Faith, we are concerned that the gains Uganda had were kind of getting worse. And over the years, as you are well aware, is that we were at the center of the response. And again, as you rightly said, it is always good to change things when they're not working. But of course, in Uganda, the concern is such that for us as faith, despite having been at the forefront, we seem to have been put at the sidelines. Although we are responding to this through the mechanisms that there are. Specifically, we as Christian organizations have been scattered in all the regions, and we are having to work as sub-recipients everywhere across the country. And that has been a very big challenge based on the previous mechanisms where our central mechanisms were being financed. And we fear that we might reverse the gains as a result of the current mechanism. Otherwise, I want to thank you very much for looking at faith as a critical component in making sure that everything becomes well. Thank you very much, Ambassador.
You know, this is really, and many of you may have maybe experienced this, and it is what happened when mega contracts were created that required people who bid on the contract to cover not only a whole district, but a whole region. And we know communities of faith may have a hospital over here, they may have a hospital over there in like 3 different districts. We still are working on a solution for that. And I think they're going to have to find that solution because of our push to only fund indigenous organizations. And so as we move to solely indigenous funding, but if you have ideas about how to create coalitions, not requiring you to cover an entire district or entire region, but to really speak to your strength, but for forming a network of strength so that we can ensure that all of the places are covered. When we went to indigenous organizations at CDC, we went from 90 cooperative agreements to 600, which is hard to manage, I just have to say. But to really do it right, we would need 6,000. You know, if you wanted each of the individual key organizations to have direct funding. And so trying to figure that out and what that should look like and forming a network of faith organizations could be very helpful. I don't know what it looks like, and I wouldn't impose that on you, but I understand your problem, and it is a huge problem in every single country. Because, again, as we discussed, many of the faith-based organizations and hospitals and clinics are often at the furthest end of the road, and the farthest end of the road in like 20 districts. So it's very difficult then for them to put in a standalone and say, I'm going to take over 10 districts. I mean, that would be impossible. So we understand it's a problem. We don't have a clear solution yet. So if you have ideas during these next 3 days, that could be very helpful to us. So thank you. Thank you for raising that, and thank you for all the questions. I learned more from the questions and where we still have difficulty. So thank you for the dialogue. It's really important for me to have that part of the conversation. So thank you. Okay.
So isn't it amazing to have somebody so passionate and so thoughtful who cares about these issues, both leading PEPFAR and taking time to come and join us for this conference. So thank you.